Good afternoon, everyone. I'm Josu Fuente. I'm a hematologist at Imperial College in London, and it's my great pleasure to talk to you today about the curative therapies for transfusion-dependent thalassemia. This is indeed very apt because, as many of you will know, on the 8th of May, we celebrate World Thalassemia Day. I am also the secretary of the Hemoglobinopathy Working Party of EBMT, and I will encourage all of you to join us and to participate in all our events. I do thank Mohammed and the team at the ICH for inviting me to be able to give this seminar. And I very much hope that there will be lots of questions and we'll be able to share experiences and to join and reach a consensus together. But first of all, I'll give you a presentation on what my views are of the current state of curative therapies for transfusion-dependent thalassemia. Those are my disclosures. So let's initiate by reminding ourselves that the globin switch is what leads to the manifestation of thalassemia. And the reason for that is because during fetal life, as you all know, we produce hemoglobin F. But as we switch off the gamma globin chain and we start to produce beta chain, there are over 250 different mutations that lead to the abnormal production of beta globin ensure that the manifestations of this condition start somewhere around 3 months of age of the life of patient. Now that switch is controlled by a number of genes, of which central to it, in the middle, you see BCL11A, of which I will say more later, but that is the central repressor of the gamma chain production. That ensures that the hemoglobin production relays on the beta chain and hence the patients develop anemia. Now, the reason why thalassemia leads to its manifestations is due to the fact that the lack of beta globin or the reduction of the beta globin chain expression alters the alpha to beta globin ratio. That means that there is an excess of free alpha chains which aggregate and precipitate in the erythroblast, both damaging the cell membranes and also causing reactive oxygen species. That is the reason why there is ineffective erythropoiesis and hemolysis. In fact, the specific alpha to beta globin ratio and the capacity for continuing hemoglobin F synthesis distinguishes between those who are going to be transfusion dependent and those who are going to have non-transfusion dependent thalassemia. Transfusion dependent thalassemia are those patients that require chronic red blood cell transfusions and ion chelation, whereas those who are non-transfusion dependent only require sporadic blood transfusions at time of particular stress, but it does lead to an increased ion absorption, and that non-transferring bound ion will eventually lead to severe ion load and organ damage. Now, all of us have an ability of around 1 milligram per day of ion absorption in our gut. That gets then stored into the bone marrow, where red blood cells are created. And as those red blood cells age, the macrophages erythrophagocyte them and recycle them back onto the bone marrow. Whilst the ion is in circulation in the blood, in plasma, it is bound to transferrin, as you can see there. And any excess is stored in the liver. But as you clearly see in that diagram, the only source of ion comes from our diet through the gut, and the only actual loss happens from the cell loss that we have in our gut. And this is very carefully balanced because we absorb 1 to 2 milligrams per day, we lose around 1 to 2 milligrams per day. Now that circulation, that processing is completely controlled by ferroportin. Ferroportin is in the macrophages, it is in the liver, in the hepatocytes, is in the enterocytes, and is the channel through which the ion moves. And ferroportin is closed by hepcidin. So if you produce hepcidin, if you induce hepcidin, ferroportin closes and you limit the ion circulation. if hepcidin is not produced, the ferroportin is opened and iron can freely circulate through these compartments. Now, hepcidin is pathologically suppressed in ineffective erythropoiesis. The reason for that is because wherever there is erythropoiesis, led by erythropoietin stimulation, by EPO stimulation, erythroferron is produced. And so in normal circumstances, you should have a situation where if there is too much iron in the body, you produce hepcidin and you stop that iron circulation. But if you have a drive of erythropoiesis because there is anemia or there is ineffective erythropoiesis leading to anemia, and you continue to have a very high drive of erythropoietin because you want to increase your hemoglobin level, that will lead to the erythroferron production. It will lead to the suppression of hepcidin, and hence, despite of being a lot of iron in the body, there will continue to be an opening of the ferroportin and a continuous absorption of iron from the diet and a continuous deposition of iron in organs like the liver. Now, in addition to that, the iron overload itself leads to erythroblast reactive oxygen species production, which causes an even greater alpha to beta chain imbalance and damages the lipids, proteins, DNA of the cells. And there is an increased GDF11 expression that leads to the expansion of the immature erythroblast, inhibition of the end-stage erythromaturation. So we have a situation that the iron overload itself leads to ineffective erythropoiesis. The ineffective erythropoiesis leads to anemia and inadequate control of the mechanisms to stop that iron overload. And so both the iron overloading and the ineffective erythropoiesis create a feedback loop that feedback one another. And so we reach a situation where there is substantial increase of iron into the patient and worsening hemoglobin production that feed back one another, leading to the manifestations of thalassemia, all initiated by that abnormal alpha to beta globin ratio. And so this is a multi-system disease initiated by that alpha beta chain imbalance. But as we have seen in the previous slide, the ineffective erythropoiesis, iron overload, and anemia feed back to one another, eventually leading to organ damage, expressed as a marrow expansion and bone disease, extramedullary hematopoiesis and organomegaly, peripheral hemolysis and gallstones, and a hypercoagulability state with vascular disease. All of this together means that despite of the very substantial advances that we have done over the last 20, 30 years with the ability to have a variety of chelators, not just desferoxamine, but also oral chelators, and to be able to address the needs of our patients with adequate MRI monitoring, which is able to target alkylation treatment according to whether there is excess of iron in the heart or in the liver or in both. Although there have been, as you can see, in those red and green survival curves, substantial improvement, the reality is that we are not quite there against the general population. So we have data from both Cyprus and from the United Kingdom, from England, and this is work that has been led by Paul Telford from the Royal London Hospital here in London. He's able to demonstrate how there is somewhere between a 5 to 15% greater mortality risk comparison to a much general population of our subjects. Indeed, altogether is probably 5 times greater than age-sex adjusted mortality rate for somebody with transfusion-dependent thalassemia. And this is very important because it allows us to understand what risks we can assume when we think about curative therapies. In fact, we know that the residual iron burden, at least in the UK patients, is too high, and one could think that this is similar in other parts of the world. the reason why it is UK data that I am showing is not just because I live in the UK, but actually because we have a fairly centralized healthcare system, which allows us to have quality of data that we can trust throughout the country. And so you can see that 3/4 of the patients have a ferritin which is too high by current standards. At least 40% of the patients have too much iron in the liver, and at least 1 in 5 patients have too much iron in the heart. And this is why, by the time a patient has received transfusions for over 25 years, over 95% of the patients have at least 1 organ damage. And the majority of the patients will have several organs, as you can see in those graphs in different colors, including the fact that 40% of the patients have endocrine abnormalities, 40% of the cases have osteoporosis, and that leads to microfractures in the spine and severe pain. A third of the patients have diabetes, and 1 in 5 patients have cardiac disease, including 9% of the patients having problems with the function of the heart and 9% of the patients having arrhythmias. So altogether, you can see the importance for these subjects to have the possibility of a curative treatment that may, on the main, have a substantial impact in reducing morbidity as they become older. Now, what do we know about the possibility of curing these patients with transplantation? And I will start first with allogeneic transplantation, and then I will move on to the new modalities of autologous corrected gene therapy. Well, the first thing that we have known, and this is work of, as you can see, over 30 years ago done by Lucarelli, that iron control determines the outcomes in transplantation, particularly with busulfan and cyclophosphamide, and this remains true to this day, even with the new agents, although there is a greater ability to tolerate iron with fludarabine-based conditioning regimens. But we know from the very beginning that iron is one of the main determinants of outcomes, and patients were able to be classified according to what became the Bessel risk classification, so that depends as to whether the patient had hepatomegaly, defined as more than 2 centimeters below the constant margin, whether they have initiated chelation treatment within 18 months of the first transfusion, and whether there was bridging fibrosis or not in the liver biopsy. And so you can see that very clearly patients could be divided in 3 different groups, and that the event-free survival very much depending on that iron situation. The second thing that we learned is that avoiding graft-versus-host disease was of paramount importance for this patient population. So when we look at good quality of life data created by the Italian transplant groups, you can see that when a patient enters transplantation, the quality of life is reduced, as you will expect, because of the chronic disease, and that drops further during the intensity of the treatment. But if you were to measure it a year post-transplantation, you can see, or a year post-cessation of immunosuppression, that the quality of life has been normalized for the majority of the patients. And those patients who have not normalized the quality of life is because they have chronic graft-versus disease. So this means that in all settings, cell therapy is of utmost importance, even in the related setting, and we ought to use it in order to minimize the chances of achieving graft-versus-host disease. In fact, we know that long-term, patients who have had a bone marrow transplant are better off in quality of life terms than those who are transfused. And so if you compare those who have been transplanted in blue versus those who have not been transplanted in red, you can see that at the very least transplantation comes equal or better at all areas that has been assessed, but particularly a significant improvement in role limitations, the ability to maintain a professional life, bodily pain, and emotional function, the ability to form a partnership with another person. Now, another element that we learned very early on in transplantation for thalassemia is that expanded ineffective hematopoiesis is a risk for graft failure. And so you can see here work done by assessing the amount of active erythroid marrow with MRI, and how those who had graft failure had a greater area of hematopoietic expansion. And so that is the basis as to why there are a variety of strategies that one can use pre-transplantation to suppress hematopoiesis, and that includes happy transfusions. For example, in my practice, we normally maintain the hemoglobin between 130 and 150, or 13 and 15 grams per deciliter for at least 8 weeks pre-transplantation, transfusing the patients every 2 weeks. But other strategies include the use of hydroxychiamide in combination with azathioprine, and for younger patients, the addition of thiotepa to the regimen in order to minimize the chances of graft failure. Now, fludarabine-based conditioning regimens undoubtedly reduce toxicity and enable not only to apply transplantation to those who have a related donor, but those who have a fully matched unrelated donor. And so the identification of the transplant regimen, including fludarabine, triosulfan, and thiotepa by Franco Locatelli's group, was able to ensure that we could apply a curative treatment to a greater number of patients, both because it's less toxic, and so we could include a greater number of patients with less controlled iron load. And indeed, in using an FTTA regimen, there is no difference in the outcome of class 1 and class 2 patients, and did allow to adopt unrelated transplantation so that those who didn't have a related donor could be made themselves available of this curative treatment. And so just to give you an example, this is data from my center, where looking at 58 patients over a 10-year period, we were able to have an overall survival of over 96% with a cure rate of 93% at 5 years. And as you can see, this has very low toxicity with only veno-occlusive disease in 7% of the patients, with prompt engraftment with a median neutrophil engraftment of 12 days, and rates of GVHD, whether grade 2, grade 4, or chronic GVHD, which are in the 10 to 15% mark, and only one patient requiring any treatment for graft-versus disease long-term beyond 18 months. Now, the main consequence of reducing the intensity by introducing fludarabine with triosulfan and dropping the double alkylated use of busulfan and cyclophosphamide is the fact that there is a very high rate of mixed cameras. And you can see there that only approximately 50 to 60% of the patients achieve full donor myeloid and T-cell hematopoiesis of donor origin. And that is okay, provided that you manage adequately the immunosuppression in order to ensure a stable chimerism long term, because there is no doubt that it's it is a regimen of very, very low toxicity. But one has to put attention to ensure that there is a stabilization. As we will see in a few minutes, is of the utmost important to avoid clonal evolution. Now, what do we know about what determines the outcomes of transplantation? So we now have good long-term data from both EBMT and CIBMTR, and you can see that we are talking about a very large number of patients of over 1,000 siblings and almost 1,500 taking into account all donors. And this is work from EBMT from Dr. Baronchiani, in which she was the first person to identify that the most important determinant of the transplant outcomes in a modern era is actually the age of the patient. So optimal outcomes are achieved below the third or up to 13 years of age. And so one needs to think about transplantation within the treatment algorithm of patients with transfusion-dependent thalassemia early on in the patient pathway, not as the kind of therapy that you provide to those whose treatment is not going well, as a last option, as a salvage option, when the standard treatment is not going correctly. So if you want the best outcomes to be achieved with allogeneic transplantation, there is no doubt that the earlier that we implement this, the better. In fact, we have now even newer, more modern data from CIBMTR. Again, over 1,000 patients across a variety of centers, not just in Western countries, but also including patients from India and China, who gets, again, 2/3 were match related, but not exclusively. And so the same story becomes very, very clear, that age is the major determinant. So somewhere around 15, 13 years of age is the cutoff at which the best outcomes are achieved. And indeed, the younger the better. You can see that the event-free survival and the graft failure rate is even better when patients are below 6 years of age. But very importantly, that there is no difference in the mother area with molecular techniques of matching between those who have had a fully match-related or unrelated transplant. Unlike it happens in sickle cell disease, both related and unrelated fully matched donors offer equivalent outcomes in transfusion-dependent thalassemia. Now, why should age be such an important determining factor in thalassemia? It might be difficult to dish this out within thalassemia itself, but we have learned why this may be from a different type of transfusion-dependent anemia, from diamond blackfan anemia, where some of the patients get transplanted not because of the transfusion dependence, but because of plastic transformation, and so they might not have been exposed to transfusions in the way that transfusion-dependent thalassemia patients always get exposed, and where the effect of iron is even more marked. And so data from the severe aplastic anemia working party of EPMT clearly shows that within the patients with TBA, those who have not received many transfusions or who have no iron overload do not get chronic GVHD, whereas those that do have a substantial greater risk of graft-versus disease. And so this points out to the rationale to a certain extent as to why age is such an important factor in transfusion-dependent anemias. Now, there is more modern data looking as to whether busulfan or triosulfan-based conditioning offer differences in a fludarabine-based regimen. So we are not looking at a combination of busulfan with cyclophosphamide, but we're looking at the modern area fludarabine-based regimens, where in many instances busulfan is combined with fludarabine rather than triosulfan. And you can see that in a younger population with intravenous busulfan, well targeted, the outcomes are very much equivalent. But once again, the factor that determines the increased mortality and the reduced long-term engraftment is that of fully matching the donor and that of the age at which the transplant is conducted. Yet again, bringing the fact that age is the major determinant on the outcome of transplantation, of allogeneic transplantation, and so that this modality should be offered early in the course of the disease. Now, many of the patients, of course, don't have the possibility of having a related or unrelated donor, or maybe they live in parts of the world where having an unrelated donor is not possible because of the costs. And that has brought a number of us to think what alternative ways we could adopt to enable those patients without a fully matched donor to be able to have a curative therapy. And that is what provides the rationale for exploring the possibility of haploidentical transplantation. Now, there are two ways of adopting haploidentical transplantation. One is the use of post-transplantation cyclophosphamide, and the other one is the graft manipulation with alpha beta depletion. I'm going to start first with post-transplantation cyclophosphamide. And for those of you who are not familiar with post-transplantation cyclophosphamide, this was first identified by Dr. Berenbaum, who was a pathologist working on tumor immunology at St. Mary's Hospital at my center, where working on skin xenografts in mice was able to see that the skin graft could last longer if the mice were exposed to doses of cyclophosphamide after the graft had been inserted. And so the reason for this is that the stem cells have a different production of aldehyde dehydrogenase from T cells, and that means that they are able to clear acrolein and all the metabolites of the cyclophosphamide. And additionally, the exposure to cyclophosphamide leads to a preferential development of the T cells towards T regulatory cells. And so bringing all this together, if you provide cyclophosphamide 3 to 4 days after the infusion of the stem cells, those stem cells are quiescent, they contain aldehyde dehydrogenase and are able to clear the metabolites from the cyclophosphamide and remain intact, and indeed are stem cells that can provide early T cells for maturation, whereas T cells which have been activated because they have recognized antigens will not be able to clear the cyclophosphamide metabolites and get deleted by apoptosis, whereas those who are non-alloreactive are able to be mature, they are able to survive, and they get mature onto a regulatory phenotype. And so post-transplantation cyclophosphamide has been fundamental in allowing the HLA barrier to be passed. So my center, in conjunction with Kenneth Cook from Johns Hopkins, Ravi Hanna from Cleveland, and Adetola Kassin from Vanderbilt, has been working as to whether we can apply post-transplantation cyclophosphamide to a thalassemia population using a reduced intensity regimen so that we are able to maintain the low toxicity of modern approaches so that we can apply this to patients who have more severe disease and are of an older age. And so we tried to replicate the original Johns Hopkins platform, which unfortunately contains a very high risk of rejection. We have added thiotepa as one of the elements that we know that is able to reduce the risk of graft rejection, or we have increased total body irradiation from the standard 200 to 400. And this latest approach that seems to be able to provide the least toxicity with the better ability for cure of thalassemia across the HLA barrier. Now, in fact, other groups working particularly in Asia, so Sarita Jaiswal in India, as does Dr. Karia, or the group of Anurag Thapan, collaboration of the MD Anderson with the Thai group, has been able to demonstrate that actually, if we want to minimize the risk of graft failure with post-transplantation cyclophosphamide and improve outcomes, what is required is the adoption of pre-transplantation immunosuppression. So this means 2 cycles at day -60 and day -30 before embarking on a TCY transplant of a combination usually of fludarabine and dexamethasone, but there are different versions, by which one minimizes the risk of graft rejection and ensures the optimization of the cure of thalassemia by this technique. Now, the alternative way of approaching haploidal transplantation is that of not just, like in the old days, selecting CD34 cells, but actually depleting alpha, beta, CD19 cells, so that in the graft we have a combination of both stem cells and effector cells, by which we mean NK cells and gamma delta cells, which are going to help us to engraft the new marrow or the new stem cells, and they are going to provide a degree of control of the infections in the post-transplant period. So this was initially pioneered by Franco Locatelli as a way of facilitating a very low risk of graft-versus disease transplant, which did not require post-transplant immunosuppression. And this was very much feasible, but that has a risk of graft failure that Selin Kovacoglu has further worked on, and by the adoption of double immunosuppression in the post-transplant area, probably is abolishing or abrogating that risk that alpha-beta depletion has of leading to either primary or secondary graft failure. Now, this technique does require a fully myeloablative FTTA approach in a way that the PTCY is able to engraft with a reduced intensity. But on the other hand, it does offer you the great advantages of alpha-beta depletion. And I speak with caution because, as you can see, this has been used on a relatively small sample of 13 patients that was presented at us this year, but achieving good chimerism with a median engraftment of around 13 days. And transfusion dependent in that group of patients is 93%, with, as you can see, no severe chronic or no grade 3, grade 4 acute GVHD. Now we'll have to see as this sample grows whether these excellent results are able to be sustained, but certainly that gives you a flavor that alpha-beta depletion is a very powerful tool to avoid grade 3, grade 4 severe GVHD. In the realm of post-transplantation cyclophosphamide, we are achieving a similar lack of graft-versus disease by adopting abatacept for the first 6 months of the regimen. Now, what is the alternative? And I appreciate that this is very complex technology of great expense at the current time. But given that allogeneic transplantation is so dependent on the age of the patient, that may have a very, very important role as we move forward. And that is, of course, of the autologous gene therapy. There are two approaches. One is that of gene addition by the use of lentiviruses, and two is that of using CRISPR-Cas technology for reactivation of hemoglobin F. I'm going to be focusing on both of them, starting with the gene addition. So for those of you who are not familiar with lentiviruses, what has allowed this technology to be applied for thalassemia is twofold. The first one is the generation of self-inactivating vectors. And so what we mean by that, and you can see at the top of the screen, we have the HIV virus so that you can compare it with the vectors that we use in gene therapy. And so first of all is we have stripped all the unnecessary genes like the enveloped polymerase and so on that an active virus will require. But more importantly is we have gone on to the UTR regions. You can have them marked in yellow, and we have inactivated those promoters of the wild type virus, so that the transgene is under the control of a cellular promoter that we have inserted. And that means that that transgene of interest will only be expressed in the particular cellular situation that we are interested in. The second element that has allowed the generation of lentiviruses, which are useful in the thalassemia or in the hemoglobin situation, was the identification of the hypersensitive sites in the locus control region in chromosome 11. So these hypersensitive sites work with a number of genes to be able to make it more effective, the transcription of the beta globin. And so they were identified and have been used within the construct to be able to produce the beta globin in our lentiviruses. So we have a cellular promoter that has been inserted within next to the globin gene, having inactivated the wild type promoters. But in addition to that, we have the hypersensitive sites that are able to increase the efficacy of that promoter. And that is the basis of the product that Bluebird Bio has a trial and which is now licensed by the FDA, Beticel, which underwent a number of studies, phase 1, phase 2 studies at the time where the product was not optimized, and phase 3 studies with the optimized product for both non-beta 0, beta 0, and beta 0, beta 0 thalassemia. This involves the generation of a new beta globin, which is called the T87Q, that is, when combined with the alpha globins, gives you the hemoglobin T87Q that is functional and which can be measured by HPLC. These are the patient characteristics of all the studies. And you can see how, as the product has been optimized, the vector copy number, the amount of corrected gene that is able to be inserted per cell has gone from 0.8 to 3.2, which explains the greater efficacy of the product, and how the number of CD34 cells that has been transduced moved from 32% to the optimized 82%. And so, though the cell dose between the early trials where there was no optimization of the product and the late trials remained the same, the quality of the product is substantially greater, both because of the greater number of vector copy numbers and the greater number of transduced cells in the product. Now, this is the data of the long-term study. And what I'm trying to show you is that long-term, there have been no adverse events related to the gene therapy product. There have been adverse events of a patient that has had correction of the thalassaemia, but of course, until that point, had the effects of the disease. And so, having gallbladder problems are not unexpected. And the more important events relate to a patient who had also a HIV infection, but there have been no long-term events related to the Beticel product. And these are the outcomes. So the point of the transplant is here at the beginning. Each line corresponds to a separate patient. And if they are in the deep blue color, it means that they are not transfusion dependent. And you have the phase 1, phase 2, and then you have the phase 3 patients, and you can see that the patients are differentiated between those who have had a non-beta 0 and a beta 0 genotype. And so you can see that if we focus on the optimized study, 90% of the patients achieve transfusion independence. And that shows you what is the total hemoglobin in the continuous line, with how much of that hemoglobin is due to the new T87Q hemoglobin in the discontinuous line. And in red, you see the phase 3 study, clearly demonstrating that once it has been optimized, the results are excellent. Now, the reconstitution over time is polyclonal. As you can see, there have been no insensual oncogenesis events, and there has been no clonal dominance, demonstrating that the inactivated the same lentiviruses are effective at what they are supposed to be doing. And over time, these patients not only achieve a normal hemoglobin level, but there is improved erythropoiesis, as you can see in those bone marrow biopsies, where we move from a hypercellular erythropredominant situation to a histology that you recognize as being normal. And that is seen also by a reduction of the ME ratio and the normalization of the soluble transferrin receptor values. And in keeping with the normalization of the hemopoiesis, it is possible to establish effective chelation or venesection strategies to reduce the iron load of these patients by normalizing the ferritin and the LIC measured by ferriscan, so that these patients are able to discontinue chelation treatment a few months or at some point after treatment has been provided. Now, the alternative way of undertaking gene therapy will be that of using CRISPR-Cas technology. So Cas9 is a nuclease, so it's able to create double strand breaks in the DNA, but those are guided by the CRISPR. So the guided RNA is a simplified form of the wild type CRISPR-Cas system, which is the way of adaptive immunity of prokaryotic cells. And so to be able to use it effectively, that truncated RNA has been simplified as a single RNA that is able to recognize a particular sequence and then bring the Cas9 to create a double strand break at an area of interest. And this is what Vertex has used in order to reactivate the hemoglobin F production. So the erythroid enhancer of BCL11A is cut with CRISPR-Cas technology so that they are indel formation and the BCL11A is inactivated in erythroid cells only. So the effect of BCL11A anywhere else, like for example in leukophoresis, is not affected because it's only the erythroid enhancer to which we have guided our technology. And the rationale for this is in order to reactivate the hemoglobin F production, and these cuts have been created ex vivo in a non-viral manner in hematopoietic stem cells that have been collected in advance. And so in common with all the gene therapy techniques, the patient is assessed, the CD34 cells are collected with the use of Plerixafor and GCSF mobilization. They then get taken to a central manufacturing facility, in this case to do the CRISPR-Cas editing, in the case of the gene addition to be used the lentiviruses in order to add the new hemoglobin. And once the product has been manufactured, then the patient has a busulfan conditioned myeloablative autograft in which his own corrected stem cells are infused. And approximately 3 months later, there is a normalization of the hemoglobin production, and somewhere between 3 to 6 months, patients are able to return to normal life. Now, the 111 study, which is for patients between the ages of 12 and 35, had a primary efficacy endpoint of ascertaining what proportion of patients were able to be transfusion independent for 12 consecutive months. And we're going to focus on those patients who have had a minimum follow-up of 16 months, what we call the primary efficacy set, so that we are able to determine whether indeed they were able to be transfusion independent for 12 months, taking into account that for the first 2 months of the autologous transplant, the patients receive red cell transfusions, and so then we have to provide a washout period so that we can see the true efficacy of the gene edited product. Now you can see the patients that enroll in these studies. A third of them were adolescents, the other 2/3 were adults, and beta 0, beta 0, or beta 0-like genotypes constituted 2/3 of the patients. And unlike in sickle cell disease, where the mobilization of the stem cells is more complex, the majority of the patients, the median of the patients, only required one cycle of mobilization of stem cells, obtaining adequate cell dose. And having had busulfan myeloablation, you can see that in common with any gene therapy product where the stem cells have been manipulated ex vivo, the median time to neutrophil and platelet engraftment is significantly longer that you would have expected in a normal autograft. But the benefit is that because we're using single myeloablation with busulfan, the time at which these patients become neutropenic is also later. And so the entire period of neutropenia is actually not very different than the normal autograft, though the patient does have to stay for longer in patient are waiting for this engraftment to occur. And so the primary endpoint of transfusion independence for 12 months consecutively was achieved in almost 93% of the patients. And you can see that the duration of the follow-up that we have is almost 2 years. So we can trust that this is a consistent, lasting result. And if we want to look at the patient's pathway individually, as we have seen with the gene addition, you have the graph here where at this point the patients had the transplant, and so the dots to the left are the transfusion events that they had previous to having the autograft. The period in red is the period at which they were still being transfused, with a washout period, so that we don't take into consideration the effect of transfused red cells. And in green, you have the true transfusion independence. And so you see that almost 93% of patients have achieved transfusion independence for 12 consecutive months, and that the 3 patients who have not met that 12 months consecutive period actually did eventually become transfusion independent at 14, 12, and 21 months, respectively. And indeed, at this point, every single patient who has undertaken exa-cel as part of the 111 study has reached the point of transfusion independence. Patients normalize the hemoglobin level at around 3 months post-transplantation. You can see the majority of that hemoglobin is hemoglobin F, and that there is no difference in the ability in the efficacy to produce this hemoglobin F, which is in a pancellular manner between those who are adults and adolescents. And looking at the allelic editing, both in bone marrow and peripheral blood, of course, we have longer follow-up and more time points in peripheral blood because it's easier to take peripheral blood samples than doing repeated bone marrow. You can see that for each given patient, the allelic editing remains stable over time, signifying that we have achieved the gene editing at an early stage hematopoietic stem cell progenitor cell, so that we can have assurance that this is going to be a one in a lifetime therapy that is not something that has to be repeated multiple times because the editing didn't occur in an early enough stem cell. Now, the effect is not just of being able to normalize the hemoglobin production of these patients, but actually we have seen improvements in the quality of life of the patients in the way that I was able to show to you that patients who have allogeneic transplantation, if they don't get graft-versus disease, are able to normalize their life. And so whether we look at the FACT-G, the general score, or the BMT subset of BMTs, so the FACT-BMT scale, for those of you who are not familiar with quality of life studies, is an instrument that has been created specifically for patients with hematological disorders. It's able to capture the symptoms and quality of life problems that a patient with a blood production problem will experience. And it's been measured at baseline, 6, 12, 18, and 24 months. And the subscale, whether that of the general score or that taking into account the particular effects of the bone marrow transplant therapy, need to be compared against what we call the minimal clinically important difference, the MCID. So this is the number of points that you have to increase your quality of life to make a difference to the lifetime, to the life of the patient. And we know this from previous studies or from statistical modeling. And you can see that the points that are increased at 24 months in the patients who have received exa-cel are above the MCID. Indeed, you may see it clearly in this graph. So these are the different subsets of the FACT-G scale, of the general scale. So whether we look at physical well-being, emotional well-being, you can see that we have gone over the yellow line, which is the time points necessary to be meaningful for that particular patient. Now, something very, very important that we're starting to understand is that when we look at the same type of work, but of course doing with an appropriate, age-appropriate adolescent scale, we also see this effect in the younger population. So the adolescent scale looks at both physical functioning and psychological health. And the psychological health is then further subdivided in emotional functioning, social functioning, and school functioning. And what I want you to see is that if you compare the MCID versus the improvement that is achieved at 24 months, the fold increase is even greater than we see in the adult population. In particular, I want to draw your attention on emotional functioning and skull functioning, which are the more liable, the more difficult areas for an adolescent to live with. And so this may also point out that we should not reserve gene therapy as something to be applied for those whose treatment is not going well, for those patients for whom there is no other option, but actually we need to incorporate gene therapy into the treatment algorithm in our patients and deliver it early if we want to achieve the best possible outcomes. Now, the adverse events are those which are consistent with busulfan maloablation. So these patients have had an autograft, and so that's the reason why all of them have had adverse events. There were only 2 cases where the adverse events could have been ascribed to the exa-cel, to the gene editing. One was a patient who suffered hemophagocytic lymphohistiocytosis, and the other one was a patient who had a delay engraftment, neutrophil engraftment being achieved at day 56. Both of these patients have recovered from the side effects and they are well. Indeed, the patient with HLH is leading a completely normal life today. And this gives you a graphical representation as to how those adverse events are time-dependent, and so the majority of them happened in the first 6 months, in keeping with having had an autograft, and they fizzle out as the patient progresses from the time where the transplant occurred. So I hope I've been able to give you an overview, putting together where I think we are with curative treatment with transfusion-dependent thalassemia. I hope you can see that fully match-related and unrelated allogeneic transplantation can lead to the correction of the hematopoiesis and normalization of the quality of life. That there is a complex interaction between age and ion load that determines the outcomes of allogeneic transplantation. And so with allogeneic transplantation, without a doubt, best outcomes are achieved below the age of 13, 15, the younger the better. And so it ought to be an integral part of the treatment options for patients and be part of our management algorithms from the diagnosis rather than to leave it as an option for when things don't go well. Now, gene therapy removes the allogeneic barrier to transplantation in the older patients, in the adult patients. But again, its outcomes are optimized when it's offered early, when we have seen from the quality of life studies, from the patient-reported outcomes, that they gain more the younger they provide it. And indeed, it makes sense that if you offer a curative treatment before there has been end organ damage, that the patient is going to gain and benefit more from that therapy. So we should move away from using more complex treatment as a treatment of last resort, maybe the way that we use complex and new agents in hematological malignancies, where often we leave the more novel or the more costly therapy for those patients who have failed previous rounds of treatment or chemotherapy, for the fourth line, for the fifth line. No. In the case of both allogeneic transplantation and gene therapy, where it is addition or editing, this is something that should be offered at the correct time, early in the pathway of these disorders. And then the other thing that we need to take into account is that allogeneic transplantation can be offered following gene therapy. So if you fail gene therapy, you can still have a related to unrelated transplant, in a way that if you have had a bone marrow transplant, you cannot have gene therapy. You cannot be rescued from gene therapy if you already have had a bone marrow transplant, because it will be impossible to collect sufficient stem cells to be corrected. So putting all this together, my view is that for those people for whom the risks of a chemotherapy in the context of transplantation are risks that are acceptable, and there are risks which, as you have seen, are within the overall risk of having thalassemia in a modern natural history, but we need to take into account the views of the patients. So for those for whom they're acceptable, they should contemplate an allogeneic transplant early in the course of the disease, particularly in the first 13, 15 years of their life. For those for whom that, for whatever reason, has not been possible, whether because there was no availability, maybe because they didn't have a donor, maybe because they have changed their mind as to what they want to do for the treatment of the disease. Once we are into an adolescent age and adult age, I would think that the optimal outcomes are achieved with gene therapy. And if we are going to move into that direction, the earlier, the better. So thank you very much. And going to stop sharing, and I'll be very, very happy to take any questions. Now, the first question comes from Dr. Khan, who would like to know whether PTCY has a role in fully matched transplantation. So the number of related transplants with thalassemia that have been done with PTCY is limited. And that's partly because more traditional conditioning regimens with serotherapy have been so effective that there has been no particular need to move onto a PTCY platform. And I suppose there is always a wish not to expose new stem cells that may produce hematopoiesis for potentially 60, 70, 80 years to chemotherapy. But in principle, there is no reason why it shouldn't be used to reduce graft-versus disease. And we know from the malignant world that it's very effective in reducing reducing GVHD. And I would think that particularly for young adults, this may be an avenue of significant interest. I have a question from Dr. Work, which says, what is the relapse rate after use of XL, and what are the mechanisms of relapse? So far, there hasn't been anyone whom, having achieved transfusion independent, has gone back to having thalassemia. Now, as you have seen, it's been approximately 100 patients, or just over 100 patients, who have received both gene editing and gene addition. So it might be just a matter of the fact that we haven't treated enough patients to see somebody on whom the patient has failed. In the case of gene addition, a proportion of the patients who were in the phase 1, phase 2 study, where the product was not optimized, a proportion of those patients did not reach transfusion independence. But I think that was more a reflection of the fact that the technology had not been made as perfect as possible at that point. Now, what it is true, in whether we talk about allogeneic transplantation or autologous transplantation, it is essential that we achieve a stable hemopoiesis. We know this from the gene therapy studies. We know this from sickle cell disease. We have seen it also in our own allogeneic program, that if you have poor graft function with unstable chimerism, you do run a risk of clonal evolution. And so I will predict that if we don't achieve good establishment of hemopoiesis by whichever method it is, that whether you use allogeneic or gene therapy, that you run a risk of clonal evolution. And that could potentially be the mechanism by which you lose your transfusion independent. A health professional that hasn't revealed its name says, very interesting data, thank you. Is there at least a haplodonor? Why would someone prefer gene therapy, which is 20 times more expensive? And are there really benefits from patient and donor, Isabel? It is certainly a very good question. At the present time, we are seeing outcomes with gene therapy, which haploidentical transplantation in thalassaemia doesn't quite yet achieve at this point. That partly reflects the fact that, unlike in sickle cell disease, where haploidentical transplantation has a very substantial experience now, both by the work that we have done in the Vanderbilt group, but also by the 1507 BMT-CTN trial. In thalassaemia, we are at an early stage. So we haven't harnessed the technology quite to the same degree. And it may well be that is actually going to give us very, very similar outcomes to gene therapy. And the question of costs and risk is very, very important. For many patients, haploidentical transplantation is accessible in the way that gene therapy is not. I think what I was trying to say in my talk is that certainly for a conventional fully matched transplantation, where full myeloablation is achieved, there is no doubt that there is an innate effect. Now, we don't know yet whether by reducing the intensity of conditioning in PTCY in the way that we do for sickle cell disease, that reduction in intensity will allow us very safely to provide this therapy for all the patients. And that is the hope, if we are able to replicate what we do for sickle cell disease, but we don't quite know it yet. And so that is the reason why at the present time, gene editing looks very, very promising. But at the end of the day, it is limited in its scope because of the cost and the complexity. And so there will be a number of patients for whom, actually, there will be many patients for whom progression to haploidentical transplantation is the correct thing today, because they want to achieve, they want to move on to a curative pathway. Have Dr. Hassan from Egypt, who wants to share his research ideas. Yes, of course. I'm very happy for the host to share my email. I'm going to give it to the host now, and they can put it on the chat. This is exclusively for healthcare professionals. I'm sorry, but I cannot answer patients directly. I can only answer emails from health professionals, and I can, of course, accept referrals of patients to be seen, but it will be impossible to engage without knowing the clinical case in detail. And then Dr. Madasu asks me whether gene therapy is considered successful. Do you suggest gene therapy instead of bone marrow transplantation in children less than 13 years? So we don't know yet, because the studies for gene therapy below the age of 12 have been conducted at the moment. The trial is the 1-for-1 trial. We do not know yet what the outcomes are going to be, so it's a bit premature to make that decision. At the moment, the licensing of the gene therapy products is for those patients who are above the age of 12 or above, and who do not have a available sibling donor. I think in a few years we might be having a different conversation, but I think it's too early to know that. So look, thank you very much, all of you. What is an absolute? I will finish with one final question from Dr. Mudassir. Absolute contraindication to gene therapy. So the absolute contraindication is, of course, the inability to undertake a bisulfite myeloablation. So at the present time, if you're going to have someone who has severe iron loading of more than 15 milligrams per gram of dry weight in the liver, you should do a liver biopsy to ensure that there is no bridging fibrosis. I personally will avoid taking on to any form of transplantation, whether gene therapy or allogeneic transplantation. Anyone who has severe iron load, we should intensify the chelation treatment and work with the patient to try to reverse them to a PESR 1 or PESR 2 class, so that the transplant is undertaken in a safe manner. So thank you all of you for joining me. Thank you for taking part and asking the questions. The talk is recorded and will be put in the website of the International Academy for Clinical Hematology. It's been a great pleasure to be with you, and I hope we can meet up. Please, as I say, do join EBMT, come to our educational activities, come to what we are working in the Hemoglobin Working Party. We embrace partners not just from Europe, from throughout the entire world, particularly from those countries in which thalassaemia is a very serious healthcare problem. And it is a working party which welcomes both transplanters and non-transplanters, so that we can move forward in delivering the best treatment for our patients. Thank you.